Kasi na nawala na. Nangyari sa akin. Let me check if function yung aking pen. Yan. Wait lang, class. Tagal ko na hindi nagamit yung aking pen. Ayan yung function. Sira na ba siya? Wait lang. Hindi pala siya nag-on. Why? Ang problema nito. Wow. Wait lang talaga. Just fixing this one. Ayun yung mag-on. Wait lang. I'll just get something. Really sorry for that. Wait lang, may technical problem lang ako. Aluwang pala yung port ng aking pen. Okay, let us start. Sige. I'll start first with the types of receptors. Since yung na-upload ko na video and at the same time material for weeks 1 and 2 is about pharmacokinetics. Let me have my discussion directly sa pharmacodynamics. So I believe we are very familiar with that pharmacokinetics, what the body does to the drug. And thus, yung topic doon sa na-send ko na materials are about ADME. Okay, absorption, distribution, metabolism, so on. And then for today, again, we'll talk about pharmacodynamics, what the drug does to the body. And under the study of pharmacodynamics are the receptors, which are substances or anything inside our body where the drug interacts. Okay, so for our discussion, we only have 4 subtypes of receptor. So we have class 1. Let me know if if hindi legible yung aking sinusulat sa screen. Anyway, class 1, these are ionotropic receptors. Again, ionotropic receptors, or ito yung ating ligand-gated na mga antigens. So, in this type of receptor, we have an example like nicotine. So, for nicotinic receptor, for nicotinic receptor, syempre, the ligand, for example, is like nicotine. And then, if the ligand binds to the nicotinic receptor, there is an ion channel that will open. In this case, it's sodium channel, yung ginigate ng ating ligand. Okay? So again, if nicotinic receptor is being activated, sodium channel will open, and then sodium syempre will enter the cell, and that will lead to depolarization. So like the inside membrane of the cell will become more positive, thus leading to the stimulation of the cell. And that explains the reason why if like a person smokes, since we have nicotine here, there will be CNS stimulation. Or kung other parts sa body, there is still stimulation depending on the cells being activated. But that is the first classification or first class of our receptors in the body. Yung ating class 2 naman, we have here the metabotropic receptors, which are G-protein linked. G-protein linked. So in this case, a receptor, if stimulated or if activated by a ligand, it's not ion channels anymore that will be open, but instead there are G proteins that are linked in this class of receptors. And this G protein will have activation of this G protein will lead to cascades of events like activation of another enzyme, and that enzyme is needed to produce secondary messengers. So examples of this G protein, we have GS, GI, and GQ. So like sa GS, if the G protein is being activated by a certain class 2 receptor, then the enzyme that is also activated using the G protein is the adenylyl cyclase. And this adenylyl cyclase will in turn be used to produce the secondary messenger camp, the cyclic adenosine monophosphate. Okay, so yan yun, GI is inhibitory, so it will just inhibit the adenylyl cyclase. Okay, so there is no secondary messenger na mafu-form. And the last one, the GQ, will activate a different enzyme leading to secondary messengers. The different enzyme is actually the phospholipase C. And then again, it will lead to IP3 and DAG na mga secondary messengers. Okay? So again, medyo mabilis ako na. I'm just giving you a review. We have this one in our undergrad. But if you have questions, you may ask me. Okay? So si class 3 is the enzyme-linked receptors. So si enzyme-linked receptors naman, the enzyme actually linked here is the tyrosine kinase. Okay? So activation of the receptor will lead to activation of tyrosine kinase, and the tyrosine kinase will lead to the response, cellular response. So depending on what organ in the body is affected. Okay, so example actually of a class 3 receptor is our insulin receptor. So our hormone that regulates our blood sugar is a class 3 receptor. If the insulin binds to its insulin receptor, it will lead to the activation of the tyrosine kinase. And we know what happens next if magtrabaho yung ating hormone, the insulin. And then lastly, we have the class 4, which is the intracellular natin na receptor. So from the name itself, intracellular, then we can say that this one is really found inside the cell. Okay? So nasa loob ng cell. Just like we have the tubulin, which is the receptor of our colchicine. Okay, our anti-gout na colchicine. So, tubulin is the protein na content or like forming our mitotic spindle, and we see that one during cell division. So it's found inside the cell, and since it's inside the cell, the response for these drugs are actually slow. So it may take hours to even days before there will be a cellular response. So nakapasunod na din yan yung rate or yung response, gaano kabilis mag-respond yung ating body. So like class 1, since class 1 and class 1 to 3 are just found in the cell membrane, so definitely they are much faster compared to class 4. But among them, class 1 is the fastest. Pasunod na din class 2 and class 3. So these are the types of receptors that we have in our body. I believe we know that our receptors are mostly proteins. 90% of our receptors are proteins. And then the remaining 10% can be lipids or nucleic acids or other substances. Okay? So again, mga proteins sila. It may be a regulatory protein, pwede din siyang enzyme. So just like the dihydrofolate reductase enzyme, which is targeted by our methotrexate. And then we also have structural proteins that can also be used as receptors. And then meron din tayong transport proteins like yung ating sodium potassium pump, which is being targeted by our digoxin. So all of them are proteins. And then again, 10% are lipids or nucleic acids. But we also have spare receptors in our body from the name itself, spare. So we have extra ones in our body. And then we have orphan receptors in the body that are actually the target for new drug development. Okay, so from the name itself, orphan, their function in the body or even their ligand are still being identified up until nowadays. So, target siya ng drug development. Okay? So, yan yung sa study of pharmacodynamics, types of receptors. But since we have a different subject for that, let's have the deeper understanding of the pharmacodynamics and pharmacokinetics sa inyong next subject. I think that will be next semester kasi pang second year ata yan siya na subject for the masters. Okay? Any question? Again, this is just an introduction. Baka may gusto kayong itanong regarding that. Wala kang siguro na, no? Wait lang. Let me see how can I share my screen here. Hindi pa siya mapaliit. Mapaliit pala. Wait lang. Share screen ulit. Whiteboard. Okay, none so far. Let me just delete the writings on the screen. Here all the reference. And then let's move on to our pharmacology proper. Siyempre starting with the autonomic nervous system. Itong pasulat na. So we will be talking about the autonomic nervous system. But before that, we have here, let's just have a diagram first. Siyempre, we have the nervous system, and then this one is further divided into two, the CNS and the PNS. Siyempre, the CNS, the central nervous system, we have the brain and the spinal cord. And then everything outside the brain and the spinal cord is governed by the PNS, the peripheral nervous system. Now, this peripheral nervous system is further divided into two. We have the efferent and the afferent division. So in our undergrad, we have the mnemonics, same, right? Sensory is afferent, motor is efferent. Okay. So again, sensory is afferent, motor is efferent. And then under the efferent division, ito na yung we have the somatic na system and the autonomic na system. So when you say somatic, this one govern the functions of the body where we can consciously control, just like our movement, our posture, those are under the somatic system. Now, syempre, on the other side, there are functions in the body that we cannot control. So, all of them na mga functions are um, involuntary. So, automatic yung kanilang function, just like our heart, like beating of the heart, pumping of the blood, our blood flow. Those are under the autonomic nervous system. And this autonomic nervous system is further divided into three. We have the enteric and yung walang kamatayang para and simpa. Parasympathetic and the sympathetic nervous system. So, sympathetic nervous system, I believe we know that, and we call that the fight or flight na system natin in the body, and si parasympa yung ating rest and digest. So both of them are controlled by two neurons. So dalawang neurons lang sila, but we have differences. So just like sa sympathetic nervous system, the outflow is in the thoracolumbar section of the spinal cord. But for the parasympathetic nervous system, it's on the craniosacral. Now, since we have two neurons, another difference is yung kanilang length. For the sympathetic nervous system, the length of the first neuron, or that's what we call the preganglionic neuron, it's shorter, while for the parasympa, it's longer. Okay? So therefore, since shorter yung sa sympathetic na first na neuron, then that neuron, or I mean the ganglion, the junction between these two neurons for the sympa, it's near the spinal cord kasi nga shorter yung kanyang first na neuron. And for parasympa, it's far from the spinal cord. However, in the ganglion, parehas silang governed by the same na neurotransmitter, and that is the acetylcholine. So again, in the ganglion or the ganglia of both the sympa and the parasympa, we have there the acetylcholine. Now, ang difference is on the neurotransmitter in the postganglionic neuron. So, syempre, our sympa is largely governed by the norepinephrine in the postganglionic, yung ikalawang neuron na yan, terminating to the different organs in the body. And si parasympa is largely governed by our acetylcholine. Now, let's have first the acetylcholine, or let's have first the parasympathicide. So again, our major neurotransmitter is the acetylcholine. Now, we have learned in our undergrad na pag acetylcholine, wala na tayong ibang isipin. The effect is are dumbbells. So diarrhea, urination, meiosis, bradycardia, emesis, lacrimation, sweating, and even salivation. And we will only get these effects if acetylcholine will interact with its receptors. So we have the muscarinic and the nicotinic receptors. So yung ating mga cholinergic drugs, let me just erase this first. Yung ating mga cholinergic drugs, let me check. I'll talk about first the cholinergic na mga agonists. So agonists because they have affinity and at the same time intrinsic activity. So itong mga cholinergic agonists natin, we can classify them whether they are direct acting or indirect acting. So pag sinabing direct acting, the drug will really bind or meron siyang affinity to either the muscarinic or the nicotinic receptors. So, meron tayong, okay, wait lang ha. Erase ko muna. Ayusin ko siya. Pasensya na sa sulat ko. Kapangit. I hope you can still read this one. So we have direct acting na mga choline esters. So we have choline esters here. So they are direct acting. And then we have muscarinic agonists. And then we also have nicotinic agonists. So sa choline esters, syempre we have there the acetylcholine. Syempre ang effect dumbbells, wala na tayong ibang iisipin dyan, dumbbells lang talaga. But aside from acetylcholine, we also have carbachol, which we use for glaucoma, owing to its meiotic na action. And then we also have drug like betanicol and metacolin. Betanicol is mostly used for urinary retention, or it may be used for post-operative and neurogenic na ill use. Okay, so again, owing to that dumbbells na effect. And then we have muscarinic agonists, like we have pilocarpine, which is also used for glaucoma. And then this one is an alkaloid, but we have a synthetic one. We have the cevimeline, the same use with the pilocarpine. This one is just synthetic. And for the nicotinic receptor, our agonist here is syempre nicotine, but nicotine will only be an agonist in the nicotinic receptor at low dose. So again, low dose siya magiging agonist. Okay, it will stimulate the nicotinic receptor. You just don't have really a therapeutic use sa nicotine, but sa practice, syempre we use the gums and the patches for just smoking cessation. Okay, so those are our drugs under the direct acting agonist. Now, sa indirect acting agonist, indirect because these drugs have nothing to do with either the muscarinic and nicotinic receptors, but their mechanism of action is on the inhibition of the acetylcholinesterase enzyme. So that is the enzyme that degrades the acetylcholine. If the acetylcholine cannot bind to the receptor, then it can be degraded by this enzyme, acetylcholinesterase. It will be degraded into choline and acetate. Choline can be recycled to make another acetylcholine. Now, itong mga indirect acting, since they will inhibit the enzyme that degrades the acetylcholine, that will result to the increase of acetylcholine in the body. So in a sense, it can it can be called an agonist kasi dumami din yung ating acetylcholine and mas madaming ano yon chance of activating either the muscarinic and nicotinic receptors. Okay, so we further divide these drugs into three also. So we have short acting, this is intermediate acting, and then we have the long acting. So for the short acting, we can easily identify them, yung ending ng kanilang name, yung onium, we have mga ano ito, mga quaternary alcohols na may mga na mayroong ammonium group. So kaya nag-end sila sa onium. So like edrophonium and ambenonium. So si edrophonium is used for myasthenia gravis, both of them actually, but we mostly use edrophonium to diagnose myasthenia gravis. So we call that the tensilon test. So what they do in the diagnosis is they administer 2 milligrams of the edrophonium IV and then wait for seconds if the person exhibits ano, yung muscle, contraction of the muscle, like ma-open na nila yung kanilang eyes. Then that's myasthenia gravis. Pag hindi, they may add at least 8 milligrams IV pa rin of the edrophonium and then see if there is yung pag-contract ng muscle. So kung na-open niya yung eyes, for example, then it's positive for myasthenia gravis. If hindi, the person may have cholinergic crisis. Okay? And then for the intermediate acting, ito yung ating mga carbamates. So for our carbamates, we can identify them in their names also. We have the stigmines like mga neostigmine, physostigmine, pyridostigmine, etc. Okay? But all of them are also used for myasthenia gravis. Meron lang tayong mga drugs like rivastigmine and yung mga kasama niya, mga tacrin, ganon, donepezil na ginagamit for Alzheimer's disease. Because we all know that acetylcholine has also a contribution to our memory. Okay. And the long-acting, we have our organophosphates. So they don't really have clinical uses except for ecothiopate, but dati lang, ecothiopate was once used for glaucoma. Pero ngayon, the use is now obsolete. Okay? But the rest are just used as insecticides like malathion, parathion, and then we have nerve gases like soman and sarin. Again, they are under the long-acting na mga cholinesterase inhibitors natin. So all in all, these are the drugs under the cholinergic agonist. Yung isipin na lang talaga natin, the action will be dumbbells and yung mga uses nila almost similar lang naman. Myasthenia gravis, yung mga indirect acting, just to increase the amount of acetylcholine in the body. So the rest are used for glaucoma, and then mga urinary retention. So by the way, if we have problems like toxicity sa mga cholinergic agonists, our number one antidote will be atropine. Okay? But we have cholinesterase regenerator compounds like pralidoxime, pwedeng gamitan as an antidote, but let us all remember na we're just going to use them at an early stage of poisoning, mga 48 hours after the toxicity. So ang tawag sa kanila, dam and the pump, pralidoxime and diacetyl monoxime, the DAM, mga cholinesterase regenerator compounds natin. Okay? Any question sa mga cholinergic agonists natin? review lang ito ha. And then, after ko mag-discuss with this one, the Simpa and the Parasimpa, I'll be giving you the remaining time to do yung mga posted activity sa Google Classroom. Okay. So, hindi din naman siguro tayo aabot ng 6:30 for this. Malapit naman na din akong matapos since naka-cholinergic agonist na tayo. And then, para matapos na tayo kaagad, let's have the cholinergic antagonists. So, I believe you all know, pag antagonist, they only have affinity, but they don't have intrinsic activity. So, they don't really elicit a pharmacologic na action on the receptor. So, yung ating cholinergic antagonists naman, nakadepende din sa ating receptors. Okay? Wait lang. Ano nangyari dito? Wait lang, plus. Sige. Sulat lang ako sa screen. Ay, wait. Wait lang. Unshare ko lang. Okay. Share ko. Screen. Makita naman. Ayun. Okay. Cholinergic antagonists, nakadepende din tayo sa ating receptor. So, we have antagonists on the muscarinic receptors. Thus, we call this anti-muscarinic, or ito talaga yung tinatawag natin na anticholinergics. And then we also have this one on the nicotinic receptor. So, for our muscarinic receptor, syempre we have the prototype atropine from Atropa belladonna and yung ating ibang species pa ng datura. So, atropine, and then we have scopolamine, which is used mostly on motion sickness. Okay? And then, what else? Ano pa yung ating muscarinic? We have here on the lungs. Wait lang, wala yung aking pen. Sulat ko na lang dito. Let's just reverse our dumbbells. Yan yung magiging action nitong ating mga anti-muscarinic agent. Again, bakit bumababa? Reverse dumbbells. Ayan, atropine, and then we have the scopolamine. And then we have those na mga bronchodilators, since we are going to reverse the dumbbells. So bronchodilators, these are the anti-cholinergic drugs for asthma. We have the ipratropium, and the newer one, the tiotropium, which has the advantage of once a day na dosing. Okay? And then we have other drugs, yung mga drugs natin for involuntary voiding, yung mga urinary incontinence, like yung ating mga oxybutynin, ating mga yung mga hindi na common drug, even the imipramine, which is actually an antidepressant drug, but it is able to bind sa muscarinic na receptor and pwede siyang maging antagonist. So, pwede din si imipramine na gamitin for elderly patients na may mga urinary incontinence. So, again, oxybutynin, imipramine, the tolterodine and fesoterodine, yan sila, darifenacin and solifenacin. Kasama yun siya dyan sa mga muscarinic antagonists natin. And then we have nicotinic antagonist. Syempre nicotine, kasi sabi ko kanina, nicotine is agonist only sa nicotinic receptor at low dose. However, if we increase the dose, nicotine will become an antagonist already. And if naging antagonist siya because of a very high dose, it will result to a lowering of the blood pressure. Yan yung magiging effect ng pag-block ng nicotinic receptor, especially on the ganglion. So that is the reason why there are other nicotinic na antagonist na ginagamit for hypertension, though they are not really commonly used, especially in a community setting, kasi most of them are given IV. Pero still, they are used for hypertension like hexamethonium. And then we have the trimethophan. Nagamit sila for hypertensive emergencies, for the management of hypertension. Okay? Kasama na dyan yung, aside from the hexamethonium, we have the decamethonium, but decamethonium is used as a neuromuscular blocking agent. Okay? And then we also have mecamilamine. So that decamethonium and the mecamilamine. But mecamilamine is used as an adjunct for smoking cessation. Okay? And then yung last neto, so, okay. Still under the nicotinic receptor, but this time our neuromuscular blocking drugs. Their action kasi is still on the nicotinic receptor. But we have two types of nicotinic receptor, the NN and the NM. So si NM yung sa neuromuscular junctions natin, yun yung maapektuhan nitong mga neuromuscular blocking drugs natin. Since acetylcholine, hindi lang siya nagkakos ng dumbbells, meron din siyang work on the memory and at the same time in our muscles. Okay? So for our neuromuscular blocking drugs, we further divide them into depolarizing and non-depolarizing agents. Itong depolarizing agent natin, actually, agonist talaga ito. It will activate first the nicotinic receptor. That is why depolarizing ang tawag sa kanya kasi on the first phase of the drug na effect, there is a temporary muscle fasciculation and twitching. Okay? So our drug here is our succinylcholine. Okay? And then our non-depolarizing agent, ito talaga yung totoong antagonist. It will really block the action of acetylcholine in the nicotinic receptors found in the neuromuscular junction. So after binding into it, there will be relaxation of the muscles starting from the small muscles sa face, and then up to yung last na magre-relax will be the diaphragm. And then the recovery will be the reverse. The first na mag-recover is the diaphragm, and then the last one will be the small muscles. Just like the muscles in our face. So ito yung mga pancuronium, rocuronium, atracurium, and cis-atracurium. So sila yon, mga non-depolarizing agents natin. Okay? So ito yung ating mga cholinergic antagonist. So again, this one is just a review. Any question? Before tayo mag-move on sa ating adrenergic na mga drugs. But before that, if baliktad naman, the poisoning is or the toxicity is because of the cholinergic agonist, let us just use our cholinergic agonist as antidote. Okay, so yung mga, especially yung mga cholinesterase inhibitors natin, mga onium, pwede din yung mga neostigmine, physostigmine, etc. Okay, anyway, sa end, we have toxicology kasi yung ating course description for this subject is like both pharmacology and toxicology. Okay, and then lastly, we have the adrenergic system. or our sympathetic nervous system, our fight and flight na system. This one is largely governed by norepinephrine in the postganglionic neuron, the norepinephrine or the noradrenaline. But certain stimuli like stress can stimulate the adrenal medulla to produce epinephrine. But the difference is like norepinephrine is a neurotransmitter and epinephrine acts as a hormone. But anyway, they have the same receptor or receptors in our body. So just like the cholinergic agonists, our adrenergic agonists are also divided into two. We have the direct acting and we also have the indirect acting. For our direct acting, syempre they will directly bind and activate the receptor. So we have two receptors but all in all five. No? So we have alpha 1, alpha 2, beta 1, and beta 2 and beta 3 for our receptors here. The four, alpha 1, beta 1, beta 2, and beta 3 are located post-synapse, that is after the synaptic left, and alpha 2 is located before the synapse. So it's located pre-synapse. So for this one, activating the alpha 1 receptor, though marami itong effects sa body, but let me just mention the major na effect. So this one causes vasoconstriction leading to increase in blood pressure. So we have agonists here like phenylephrine, which we use as a nasal decongestant that is owing to its vasoconstricting effect no, na maluag ato ang airways. Okay? And this one naman can actually cause relaxation of the smooth muscles, including the blood vessels. So in a sense, it may cause vasodilation or it may even inhibit, since this is located pre-synapse, it may inhibit further release of our norepinephrine. So the effect may be there will be a decrease in the blood pressure. So examples of our agonists here, yung mga antihypertensive natin na drugs like clonidine, and then and then we have our methyl dopa. Okay. And then for the beta 1, this is usually found in our heart. So major location is in the heart. Thus, increase ito lahat, increase ang heart rate, positive inotropic, chronotropic, and even dromotropic na activity. So chronotropic, inotropic, and dromotropic. So we have drugs like our Dobu and dopamine here that acts on the beta 1 receptors. And then this beta 2 receptor, though also just like the other receptors found all over our body, but the major location is on our bronchioles, in our lungs, and this leads to bronchodilation. So ito yung mga drugs natin for asthma, like our salbutamol or albuterol, and then we have ritodrine also, and then we also have LABA, long-acting na mga beta-2 agonist. We have salmeterol and formoterol. So beta-3 natin will just lead into breaking down of our fats. That's lipolysis. So ang ating ligand norepi and then epi, but actually can add dopamine here. And then meron tayong yung kanyang affinity is more on the beta receptor but it's not selective. Idagdag din na lang si isoproterenol. Okay? Hindi yan siya selective for the beta receptors. And then we also have mixed acting agonist for our adrenergic receptors. Mixed acting like ephedrine. Since mixed acting siya, meron siyang activity on the beta receptor, and that is the reason why it can be used for asthma. So ephedrine, pseudoephedrine, which is not which is not really used in the Philippines, but nevertheless, it's a mixed acting agonist drug. Pero ginagamit siya as nasal decongestant. And then we have phenylpropanolamine also. Okay? And then we have indirect acting for our indirect acting. Syempre, they also have nothing to do with the receptors, but other indirect acting, yung kanilang mechanism of action is just i-increase ang displacement of the stored catecholamines in the nerve terminal endings. Okay? So, di ba, sinustore natin yung ating norepinephrine in the vesicle, and then through the process na exocytosis, nalalabas yung ating norepinephrine. And pag nalabas na siya outside in the synaptic cleft, it is now able to bind sa mga receptors. So, itong mga drugs na ito, itong increase ng displacement of stored catecholamine will lead to the increase of like norepinephrine, amount of norepinephrine na pwedeng mag-bind sa receptor. So, ito yung mga drugs like amphetamine and those amphetamine-like drugs. Amphetamine, tyramine, which can be found in our food, like chocolates, like mga wines natin. Meron yan siyang tyramine, and tyramine can cause displacement of our stored catecholamines in our nerve cells. Okay? Again, leading to the increase of norepinephrine in the synaptic cleft. Okay, amphetamine-like substances like modafinil, ginagamit for narcolepsy, sibutramine, which is FDA-approved drug for obesity kasi ano siya, appetite suppressant. And then yung methylphenidate na just like amphetamine, ginagamit natin for ADHD. So yun yung examples ng ating indirect acting drugs. And then meron pa tayong isang mechanism of action, and that is inhibition of the reuptake of norepinephrine. So, di ba, when we studied the synthesis of norepinephrine, kasama dun yung norepinephrine transporter. So, the net. Ang trabaho ng net is on the reuptake. Ibabalik niya inside the neuron, the nerve cell, yung supposedly na-release na norepinephrine. Actually, 90% of the released norepinephrine is taken back to the cell. And inside the cell, it can be degraded because MAO can be found there sa loob, the monoamine oxidase, an enzyme that is capable of destroying it, the norepinephrine. So drugs like cocaine, our local anesthetic cocaine, drugs like, I forgot the other one. What was that again? The reboxetine pala, reboxetine is also included there. Okay, and then our tricyclic antidepressants also can inhibit the reuptake of norepinephrine. So ito yung gist lang ng ating mga drugs, mga adrenergic agonists natin na drugs. Okay? Let me know if you have clarifications pa. Anyway, review lang naman ito. And then, after that, mag-move on tayo sa different na mga organ systems natin sa PICOL. Yung mga drug classifications natin, therapeutic classifications. And then lastly, syempre, we also have adrenergic antagonists. So like, depende din ito sa receptor. Like kung alpha receptors, we have, for alpha receptors, meron tayong non-selective na mga drugs like phentolamine and phenoxybenzamine. We use them for pheochromocytoma. Okay? A condition where we have, like, the patient has tumor sa adrenal medulla, and that tumor is capable of producing a lot of epinephrine and norepinephrine, leading to hypertension. So these two are non-selective, but both alpha-1 and alpha-2. Pero if we say alpha-1 antagonist, ito yung ating mga selective natin, those drugs that end with, zosine, like prazosin, toxazosine, we even have tamsulosin. So aside from being an antihypertensive drug, since it will inhibit alpha-1 receptor, these drugs are also used for benign prostatic hyperplasia. So yan yung mga drugs. Our problem with the sosins are they are notorious of causing first dose syncope. So that is why, since it can suddenly decrease the blood pressure on the first dose, we usually taper the dose or we give them at night. Okay? And then we have some alpha-2 na selective receptors like euhimbin, which is not really common, but euhimbin is used for erectile dysfunction. And then for beta-1 receptor na antagonist, syempre we have our beta blockers, or that is what we know as our olols. And then beta blockers are further divided to whether it is like non-selective, kung non-selective siya sa beta-1 and beta-2, just like propranolol. And then we have cardio-selective, so selective lang sila sa beta-1. We have drugs like metoprolol, atenolol, etc. And then we have also mixed acting na ano, wait lang, may no. Mixed acting sila, meaning meron siyang inhibition na activity both sa alpha and beta receptor. So drugs like carvedilol and labetalol under silang dalawa doon. And then meron tayong antagonist na merong partial agonist activity. So yun yung last na classification of our beta blockers. But we don't really have inhibitor of our beta-2, no? Kasi if we inhibit beta-2 receptors, then that would mean bronchoconstriction. And mahirap yun siya. As well as the beta-3. So yun lahat yung ating mga adrenergic antagonists. Okay, any question or clarifications about that? It's gonna tapos. Hindi naman masyadong nagmamadali. Or any question about our review, overview actually, of our autonomic nervous system? Any questions or clarifications? Wala. Pag wala, again, I'll give you the remaining time to start doing the posted activities. I will be posting yung para sa week 3 actually na case study. But then again, just like what I said last meeting and kanina, don't be pressured with the deadlines. So I believe we are all working and we are all busy. Pero, pwede niyong gamitin yung aking remaining time para hindi magtambak yung inyong gagawin. Kasi so far, yung aking na post dyan, dalawa pa lang naman yung sa analysis under sa week 1 na case study, and then yung application na part, which is you have to read the journal article and then you critique it or you make a review of the journal article. So you provide your insights. And then sa week 2, the same lang yung gagawin sa week 2 ha. Ang sa week 3 yung I have to post pa. Just wait for it. Pero it's the same thing. Case study pa rin yon. And a journal article. Tapos next week will be asynchronous. Pero sa asynchronous, I will be posting a case study that you need to answer, and then yung case study na yon na ipopost ko for next week na asynchronous class is kasama sa report ng mga reporters sa March 2. So yun yung gagawin natin with our class. Yung mga hindi nakahabol kanina sa pinakita ko na topics, I will just be posting the list of the reports and the assigned reporters with the schedule that he just complete the schedule first because I'm waiting for the whole schedule including the exams para hindi ko na siya isali sa pag-assign ng reporter. Okay? Any question or clarification or any concern before mag-end? Before tayo mag-end with our Zoom? Wala? Sure na? Magpaspas kay ko.